Well, welcome to this talk on the homeostasis of blood pressure. And I'm starting to draw at the bottom of a page. And what we have here is the arch of the aorta. And the aorta is leaving the left ventricle. Blood's going into there from the left ventricle via the aortic valve. Blood's here is going down, of course, towards the thorax, the abdomen, ultimately to the iliac and femoral veins to go into the legs. Now, there's a branch leaves on the right hand side here, like this. Branch leaves the aorta, a large arterial branch. And this branch here is called the brachiocephalic trunk, leaving the aorta. And as the name suggests, the branch is going to go around there. That's the subclavian artery taking blood towards the brachial artery in the arm. But what we're interested today in here is this branch here that's going up like this, and this branch here is the common carotid artery, and it's on the right hand side, so it's the right common carotid artery. It divides from the brachiocephalic at the junction between the sternum and the clavicle. The sternoclavicular junction is just above that. There's also one on the left side, but the left carotid artery leaves directly. It doesn't go via a trunk. That goes up there, and that forms the left. That's the left common carotid artery. So we have the right common carotid and the left common carotid. Now, the reason it's called the common is because it's common. It contains essentially what is going to become two arteries, because this is going to divide. So it divides into the external carotids on both sides, and they go off and supply things like your ear and the side of the scalp with blood. But it also goes into the internal carotid here. Now, just after the internal carotid has divided off from the common carotid, there's a widened area like this. So there's a widened area before this artery carries on. And this artery actually carries on and goes through the base of the skull to take blood into the brain. And this widened area here in the internal carotid arteries on both sides, it's called the carotid sinus. So we have the right carotid sinus and we have the left carotid sinus. Now, why are we doing all this for the homeostasis of blood pressure? Well, what we have here in the arch of the aorta is there are specialized receptors called baroreceptors. Baroreceptors means to do with pressure. Baro is pressure. Like a barometer will tell you what the atmospheric pressure is, so you know if it's going to rain or not. And in the walls of the carotid sinus there are more baroreceptors. Pressure detecting receptors. So in the walls of the aortic arch and in the walls of the carotid sinuses. Now, I hope you've started drawing this at the bottom of a page here, because we need to go up to the top now. Because what we've got at the top here, as you know, is we have the brainstem. And the bottom part of the brainstem is the medulla oblongata. And within the medulla oblongata, we have the cardiovascular center. The cardiovascular center. Just there. And the cardiovascular center is receiving information from the baroreceptors. So information from these baroreceptors is going to go up via sensory nerves all the way up to the cardiovascular center in the medulla oblongata. And it's the same with the baroreceptors. These are going to collect together as well, and sensory nerves are going to go up, taking information into the cardiac and the cardiovascular center. So the cardiovascular center is there. Now, interestingly, these from the arch of the aorta here, these are sensory branches of the 10th cranial nerve. And you know what the 10th cranial nerve is. so I don't need to tell you. So branches of the 10th cranial nerve go from the aortic arch all the way up to the cardiovascular center. 10th cranial nerve, of course, is the vagus nerve. And branches from the baroreceptors in the carotid sinus are going to go up again towards the cardiovascular center, and these are sensory fibers of the 9th cranial nerve. Do you know that one? The 9th cranial nerve is the glossopharyngeal nerve. So these are all taking this sensory information up towards the cardiovascular center in the medulla oblongata of the brainstem. Now there's actually two reflexes are working here. There's the aortic reflex and there's the carotid sinus reflex, but they both work essentially in the same way. Now, if there's an increase, let's think about the carotid sinus, for example. Now, if there's an increase in blood pressure stretches the wall of the sinus. So if there's more blood pressure here, that's going to stretch the wall of the sinus, the carotid sinus. Remember we said that blood pressure can be considered to be the pressure of the blood against the vessel walls in which that blood is contained. So if the blood pressure goes up, that's going to stretch the carotid sinus, the walls of the carotid sinus. And of course the baroreceptors are in the wall of the carotid sinus. So that stretching is going to activate the baroreceptors. So now let's think about what happens when blood pressure falls. So now if there's a reduction in blood pressure, and of course these are perfectly located, aren't they? Because this is monitoring the pressure of the blood that's going into the brain. These are going up to the brain. And of course if your brain's not confused, then, if your brain's not perfused, rather, that's not good. You're going to die. It's absolutely essential sort of gatekeeping position here. So blood pressure falls, there's going to be reduced stretching of the baroreceptors, reduced stretching of the walls, and that's going to reduce the rate of baroreceptor firing. So the blood pressure falls, there's going to be less stretching of the baroreceptors, and that's going to reduce the rate of baroreceptor firing. Right, so that means there's reduced numbers of nerve impulses going up to the cardiovascular center. That's going to be reduced numbers. Now, when we're talking about neurological impulses, any one nerve fibre can carry a lot of different information, but it's not done by different voltages of the individual waves of depolarization. They're all the same. This is what we call the all or nothing principle of the activity of nerve fibres. What actually happens is there's changes in the frequency of nerve firing. So they can fire slowly or they can fire quickly. So if there's reduced impulses, there's going to be a slower rate of firing going to the cardiovascular center. And of course the cardiovascular center is able to detect that. So when the cardiovascular center detects a reduced rate of firing, it knows the blood pressure has been reduced. The blood pressure has been reduced. And then the cardiovascular center will respond. And the cardiovascular center will respond in an appropriate way, as you would expect. And specifically, what's going to happen is the cardiovascular center is going to have differential activation of the sympathetic and the parasympathetic outflows. It's going to be differential outflows. So if blood pressure falls, there's going to be reduced stretching, reduced rate of baroreceptor firing. The cardiovascular center therefore knows that blood pressure has been reduced, and it will respond by reducing parasympathetic activity via the vagus nerve. That will be reduced, and sympathetic activity will be increased. Sympathetic activity will be increased via the cardiac accelerator nerves. And this is going to increase heart rate, and it's going to increase stroke volume. Therefore, it will increase cardiac output. And if we increase cardiac output, that's going to increase blood pressure. Because hopefully now you've memorized the equation. Blood pressure equals cardiac output multiplied by systemic vascular resistance. So now cardiac output has been increased, and that's going to bring blood pressure back up. Going to bring blood pressure back up. So the sympathetic activity is going to increase, and the parasympathetic activity via the vagus nerve is going to decrease. So this is going to have these effects on the heart. But as well as that, distributed throughout the cardiovascular center, there are other neurons which used to be called the Vasomotor Center. So we used to call it the Vasomotor Center, but now it's not really a center. We know it's just distributed throughout these are nerves distributed throughout the cardiovascular center. So the Vasomotor Center, when the blood pressure drops, is going to increase sympathetic outflow. And when we have increased sympathetic outflow, that's going to affect many blood vessels in the body. And what it's going to do is it's going to constrict them. They're going to become constricted. And this vasoconstriction happens in a lot of the arterial vessels in the body, but primarily at the level of the arterioles. There's going to be vasoconstriction. So that means instead of having all this space for the blood to get through, the blood is now forced to go through a smaller channel. And that's going to increase the pressure because we increase the systemic vascular resistance. So the more systemic vascular resistance, the higher the pressure is going to be. It's a bit like if you put your thumb over the end of a hose pipe, you're going to reduce the lumen of it, and you can spray people, you increase the pressure. And of course, vasoconstriction is exactly what we want when the blood pressure falls, because that's going to increase systemic vascular resistance. And if we increase systemic vascular resistance, we increase blood pressure, because blood pressure equals cardiac output multiplied by systemic vascular resistance. And as well as that, increased sympathetic outflow can affect another area of the body, the glands above the kidneys, the adrenal medulla in there. And they will cause this increased sympathetic activity will cause the release of adrenaline and noradrenaline from the adrenal medulla. That's epinephrine and norepinephrine from the adrenal medulla. And adrenaline and noradrenaline are going to be powerful vasoconstrictors. And as we know, they're also going to increase cardiac activity. So all of this physiology is going to be stimulated when blood pressure falls. Reduced stretching, reduced rate of baroreceptor firing. Detected by the cardiovascular center, reduced parasympathetic activity, increased sympathetic activity to bring the blood pressure back up, thereby maintaining homeostasis. What will happen if the blood pressure increases? Because we don't want the blood pressure to be too high either. If the blood pressure increases, what will happen? Well, if there's an increase in blood pressure, the baroreceptors will fire faster. There'll be an increase in the frequency coding of the information going to the brain. And that will be detected, of course, by the cardiovascular center. And in this situation, what the cardiovascular center will do is it will increase parasympathetic outflow and decrease sympathetic outflow. So that means that there's going to be a reduction in heart rate and stroke volume. Therefore, there's going to be a reduction in cardiac output. And of course, if there's a reduction in cardiac output, as we know, that's going to reduce blood pressure. Now, the increase in parasympathetic activity is not going to cause vasodilation to lower systemic vascular resistance. It's not. But the reduction in the sympathetic outflow, if there's a reduction in the sympathetic outflow, that will allow for vasodilation. So basically, the peripheral arterioles are constricted by sympathetic tone. So there's constant stimulation of the sympathetic nervous system to constrict them. And if you take away that sympathetic tone, then they will naturally dilate. And if they naturally dilate, that will lower systemic vascular resistance. So the reduction in sympathetic outflow when the blood pressure increases is going to allow for natural vasodilation of the peripheral arterioles all over the body. So that's going to affect systemic vascular resistance. And in fact, the vasodilation will lower systemic vascular resistance. So if we lower systemic vascular resistance, that too is going to lower blood pressure, bringing it back down to the homeostatic norms that we want. Now, overall, this is called a negative feedback system. Because if there's more impulses going in, that's going to have a negative effect on the outflows. There's going to be reduced physiological response. So that if there's more impulses going in, there's going to be reduced heart rate. There's going to be reduced stroke volume. There's going to be reduced cardiac output. And plus there's going to be a reduction in active vasoconstriction, allowing for passive vasodilation. So we notice that in this cardiac centre, in the medulla oblongata, there are interconnected networks of neurons that are going to affect heart rate, stroke volume, therefore cardiac output, systemic vascular resistance. These are all going to be regulated via this Vasomotor Center. So if there's a change in posture, then the blood needs to go, if you stand up, the blood needs to go uphill to get to the brain. So we need increased sympathetic activity. And we also need the correct distribution of blood around the body. And that's exactly what this vasomotor tone can achieve. So if we're exercising, we want more blood going to the myocardium and more blood going to the skeletal muscles. If we're resting, we want less blood going to the skeletal muscles and more blood going into the gastrointestinal tract to facilitate digestion. So it's going to control the distribution of blood around the body. And this distribution can be a major problem, for example, in distributive shock. So in anaphylactic shock, there can be a widespread vasodilation. There's enough blood, but it's not distributed properly. It's in the wrong vessels. Anaphylaxis can cause vasodilation, as indeed can sepsis. So septic shock and anaphylactic shock are sometimes described as distributive shock. The blood is there, but it's not properly distributed around the body. Or just to take another really simple example, the vasomotor component of the cardiovascular center, by differential control of vasotone, is going to allow for peripheral vasodilation when we're too hot. So when we're too hot, there's going to be peripheral vasodilation. The vessels are going to get wider near the surface of the skin. That lets more warm blood go to the surface of the body, which allows its heat hopefully to be lost to the environment, thereby facilitating thermoregulation. And because the body is efficient and wants to retain fluid if it can, this vasodilation, when the body is too hot, will occur before sweating. The vasodilation will occur first. And it will occur as a result of the sympathetic outflow being decreased to allow for peripheral vascular vasodilation. And of course, blood pressure can drop in pathological situations as well. So remember that our patients can develop what is called hypovolemia. Hypo means low, hypo, vol-emia, low blood volumes. So for example, this can happen in shock, where the tissues of the body are not properly perfused because there's a hypovolemia. And hypovolemia can occur if there's hemorrhage. Internal or external hemorrhage. It can occur if there's burns. Burns is classic for causing hypovolemia. And of course it can occur in dehydration. And dehydration can be caused by not enough fluids going in or too many fluids going out, classically in diarrhea and vomiting. And dehydration, of course, is a particular problem in children. And it's a particular problem in children because they have less blood. They can lose less of their body water before they become hypovolemic and before they become shocked. So neonatal children might have about 85 mils of blood per kilogram, but of course they don't have many kilograms. And older children have probably got, let's say, 75 to 80 mils of blood per kilogram of body weight, but they have less kilograms, so they have a lower blood volume. So they're prone to dehydration. And tragically, many children do die globally from simple diarrhea and vomiting, and the dehydration is associated with that causes hypovolemia and leads to shock. So let's think what this has got to do with the physiology we've just considered. Well, if the blood pressure drops, of course, there's going to be compensatory mechanisms that are going to bring about homeostasis of blood pressure. So let's suppose that this is blood pressure here and time here. Now, if there's progressive loss of fluid, whether it's blood or body fluid, whether it's caused by hemorrhage, burns or dehydration, in adults, the heart rate is going to increase first, of course, especially in old adults, but the blood pressure, the heart rate is going to increase and the blood pressure can sort of start dropping off, and you might think, oh dear, this person's becoming a bit hypotensive, I better do something about this. We kind of have a bit of warning that things are going wrong. But children are absolutely brilliant at this physiological compensation that we've considered. So the child's blood pressure, if they're progressively losing blood or progressively losing fluid due to dehydration, then their blood pressure can be maintained absolutely brilliantly. They are just brilliant compensators. And the blood pressure can be absolutely, basically okay. But what happens is, all of a sudden, they reach a decompensation point just here. They reach a decompensation point. And they are no longer able to compensate. And they decompensate very rapidly. And we're going down into areas here which are not associated with survival. They have very rapid decompensation. So with adults, older adults especially, we have a bit of time, we can take the blood pressure, we'll notice the heart rate is going up and we can start putting up our drips and compensating. But with children, we don't have that luxury. This is why it's so important to get a good history from children. How long has the child had diarrhea for? How long have they been vomiting for? Is the child becoming dehydrated? What is their urine output? Does the low urine output suggest that the child is becoming dehydrated? Because the dehydration can develop, but the blood pressure be maintained. Or if we're bringing a child in after an accident, we talk to the paramedics and say, well, was there much blood on the car seat? We try and get the history to try and ascertain how much blood had been lost, because we don't want to be anywhere near this point. So with children, we want to be treating them here, or here as soon as we can, basically. We don't want to be waiting for them to decompensate, and we certainly don't want to be anywhere near this terrifying cliff edge here. All because children are so good at this physiological homeostatic regulation of their blood pressure.